I'm going to talk about nutrition. So I'm doing this in a slightly different way to normal. Anyway, okay, so nutrition critical care. So essentially what I was going to talk about is, I mean, it's quite a dry topic, but it's quite important. And it's something that does seem to make quite a significant difference to patients. And you're aware, certainly at the Royal, and we often have Moira telling us what to do. And Jess as well, and often saying, you know, hurry up, when are you going to start feeding, when are you going to start feeding. So I was going to try and outline some reasons why they go on about it, and also why we go on about it as well. So what I'm going to try and talk about today is what I've written there. So the first thing is really just talk a bit about some of the physiology. So our brain uses about 18% of our metabolic of our metabolism, and essentially there are three main fuel sources that we have to be aware of. There's sugars, carbohydrate, fat, and protein. And the reason I like to think about this is that really most of what our body does is keep the brain alive, or keep the brain functioning, because without a brain you aren't much good. And it's the same with CPR. You know, CPR, although it's about getting the heart restarted, but the main purpose of CPR is to keep the brain alive. And it's the same with metabolism. It's all about ensuring that the brain has enough energy to function. So how does this work? Well, the main common pathway is acetyl-CoA, which feeds into the Krebs cycle to produce energy. And so all fuel sources essentially heading towards acetyl-CoA, which I've put there in the middle. And the way substrates become acetyl-CoA is brought, if you're looking at fat, protein, and lipid, you can see them around the outside. Essentially, I've tried to basically reduce it to as simple forms as I can. So glucose is one I'm probably most familiar with glucose metabolism. So glucose is generated, gluconeogenesis, also the mobilization of glycogen stores. Glucose undergoes glycolysis, and that feeds directly into acetyl-CoA. That feeds directly into Krebs cycles, that produces ATP. Protein does something similar. I mean, it's not glycolysis, but it goes through a very direct pathway to acetyl-CoA. So protein becomes amino acids, and amino acids themselves can directly feed into acetyl-CoA. So those two are relatively straightforward. Fat, or lipid, on the other hand, is a little bit more complicated. So first of all, lipid does break down to glycerol, and glycerol can then feed into glucose. So glycerol is metabolized to glucose, which undergoes glycolysis to acetyl-CoA. So there is a direct pathway from lipid. But most of what we're familiar with, and most of what we often see when it's not functioning correctly, is lipid to free fatty acids. Now, free fatty acids via beta oxidation become acetyl-CoA, so that's fine. The problem is free fatty acids don't cross the blood-brain barrier, which is a bit of a problem for the brain. So to get around that, free fatty acids are metabolized to ketones, and ketones can cross the blood-brain barrier, and there they can feed into acetyl-CoA in the Krebs cycle and blah, blah, blah. So the problem, though, obviously, is that we see is that when glucose metabolism is impaired, such as when you due to a lack of insulin, you produce, to keep the brain alive, produce a lot of ketones, and those ketones are supplying the brain. But obviously, as we all know, ketones generate an acidosis and cause other metabolic problems. But the reason the ketones exist is A, from lipid metabolism, but B, because they cross the blood-brain barrier, unlike free fatty acids. So that's kind of a little bit on that. When do all these happen? So what I'm doing now is talking about starvation. And essentially, your carbohydrate that you eat is essentially metabolized within about 2 hours. you do store glycogen. And there seems to be a lot of varied time courses for glycogen in most of the literature, but it seems to be somewhere with basically a day. 2 to 16 hours is how long your glycogen stores last for. I think it's probably less than 24 hours, but your glycogen is enough to provide your energy requirements from between about 2 and 16 hours. And similarly, glycerol doesn't provide a lot of energy, but 16 to 2 days, 16 hours to 2 days. The kind of crossover period is really where your glycogen stores are becoming less sufficient and your glycerol isn't able to keep up with the metabolic demands in starvation. And that's where your lipid becomes predominantly metabolized. And this is where you start to see ketones. So you'll hear us talk about, you hear us on Ward Rounds talk about starvation ketosis. Well, this is why it's happening. So free fatty acids are being utilized as the primary energy source at about 2 to 4 days in the absence of dietary carbohydrate and having fully used up your glycogen and glycerol. And then after about 4 days, once you've essentially used up your fat stores, you get onto protein degradation. And that is about day 4. And what you see is actually resolution of the ketosis, or at least a fall in ketones. And then proteins degrade essentially until you die, which is a bit miserable. So, and that time of death can be sort of 7 to 14 days. So none of this is, there are no clear borders between where these things are happening. So sometimes they like to think about that little box on the right to shows that this happens, it's like a continuum. As the levels increase, certain other levels decrease. So you can see that ketones become sort of predominant around about the 2 to 4 day period, but there's still some glucose around, it's just not insufficient. And then as protein starts being utilized for energy, the ketone levels slowly start to drop and the glucose levels start to increase. And you'll see this if you're measuring CSF continuously over that period of time. This is the sort of levels you'll see the glucose initially being predominant, then ketones, and then back down to glucose again. So that's some idea about the time course of starvation and what happens and how we use our fuel sources. How's it regulated? Well, the 3 big hormones, the main 2, obviously insulin and glucagon, but also growth hormone has a function as well. And is all again geared towards mobilizing fuel sources for energy. So for growth hormone, mainly fat. What happens in critical illness? Well, critical illness is a bit like, or can be a bit like, acute starvation. But on top of that, you have enormous energy requirements. And the key feature of critical illness and nutrition is catabolism. And you'll see this, and you must have seen this for anyone who's done any ICU, how much weight or how much muscle mass patients lose. In fact, patients often gain weight, but most of that weight is extravascular fluid. But when they mobilize that fluid again, you can see they often look quite skeletal compared to how they came in. And it really doesn't take very long, so 2 or 3 days of sepsis and your muscle mass is completely degraded. So things that cause, these are things that contribute to catabolism. So, the inflammatory response itself, metabolic stress, also the response of the stress response, the endocrine stress response, and also not using your muscles means that there's less incentive for them to, well, less incentive, not a very good word, but anyway, immobility leads to muscle loss because they're not being exercised. And obviously, if we worsen this on malnutrition, that also, we fail to keep up with the losses, then catabolism can run away. So the metabolic response to injury is quite an old theory, and it's often referred to as the ebb and flow theory. And I think it's a way of thinking about it. It's a bit like a tsunami. You can have the ebb before the tsunami, and then you have the wave of water come over you. So we often manage patients during the flow period, but we often see patients when they present in A&E in the ebb period, and that's where patients are in shock. And during periods of shock, your body, for want of a better word, shuts down. Oxygen consumption decreases, become acidotic, your enzymes become less active, your mitochondria also hibernate to an extent. And this is sort of the prelude to what happens as your body then tries to heal or recover from that shock, and you end up these two areas of flow. The catabolic component, which is what we see, so we managed to keep patients alive beyond the shock period, beyond the ebb, and now there's enormous mobilization of fuel stores, but also protein, so fat and protein, and you get huge amounts of nitrogen excretion. So if you sort of as the protein is broken down. And it's really a big feature of sepsis or recovery from shock is this nitrogen excretion and losing muscle mass. And then if they survive that period, there's a flow anabolic period, and that's where patients are starting to recover. So that's when you start seeing the water being metabolized. So their urine output starts improving, their appetite starts to improve. And this is a period of time where they're trying to patients are trying to regain their protein, hold on to their protein, restore fat deposits, and hopefully, with enough time, which can be months, regain their weight. And I put dysregulation in here because this is actually quite a dysregulated pathway. I mean, shock and sepsis are often referred to as dysregulation, and by all rights, most patients should die, but our job has been to stop them dying. And so we're trying to get them through this very dysregulated pathway of hibernation and catabolism. So what does it mean for us? Well, the key thing that's often talked about is that malnourished patients do badly on ICU. If you don't feed patients on ICU, they tend to die. But we aren't generally that mean. Often we do feed patients, but if you're inadequately feeding patients, it can take longer for them to wean from the ventilator because they have to try and recover all that muscle, and particularly around the diaphragm and the intercostal muscles. Wounds don't heal as well. Infection is more common. There's another kind of talk I can give about sepsis, but one of the things about sepsis is that a lot of patients, or probably most of our patients in ICU, don't actually die from the initial acute septic episode. It's subsequent infections that tend to kill them, and so that's very much related to impaired immune function. Impaired immune function is also a function of malnutrition. So what are we trying to do in nutrition? Well, keep things as they are. We need to provide energy. We need to try and minimize the effects of catabolism. In truth, we actually can't. Despite our best efforts, it's actually almost impossible it is essentially impossible, as far as we know, to prevent catabolism. So patients are going to lose weight, they are going to lose muscle mass. And what we try and do is minimize the impact of that. And the idea is fundamentally to try and improve patient recovery. So this is a little slide just on assessment about how you establish whether someone is malnourished or not. So one of the important questions, and I think is particularly with the chronic disease burden we see in our population, is the history. So a lot of patients come to ICU already malnourished, which obviously makes their recovery that much more difficult. And also, you'll hear us as consultants and obviously the senior registrars and people with experience of ICU will often talk about cachectic patients not doing well on ICU, and they don't, and it's because they're already in a malnourished state and then they're going through an ebb and flow period. But from the history, you have an idea. So chronic disease, but also alcohol consumption, heart failure, lots of things that affect appetite, affect nutrition. And when you come to examine patients, the two areas I find very useful are the temporalis muscle, as you can see in the bottom of the slide, the man with the black triangle for eyes. You can see right there He's got sort of sunken hollows in the side of his head, and that's sort of temporalis muscle. And if you go around ICU, and I encourage you over the next week or so, when you see ICU patients, have a look, and you'll notice how many of them seem to have sort of hollowed out faces. And the other place is that sort of fat pad between the thumb and the first finger, which, if you look in yourself, should be fairly predominant, but on patients is often absent or missing, and that's sort of getting one of those small muscles that atrophies. Albumin is something we talk about, and I think it's just important to mention that when we talk about albumin on ward rounds, we don't use it as a marker of nutrition. Albumin itself is a very poor marker of nutrition in the critically ill. So pre-admission and pre-hospital, it can be useful. So if their pre-morbid albumin is low, then that suggests they are malnourished. But in ICU, because of the effects of fluid mobilization and fluid leak and protein leak, albumin is not helpful. So when we're correcting an albumin in ICU, we're not doing it to make them more nourished or anything. It's purely trying to maintain some kind of intravascular volume. Whether it does that or not is open to debate. Electrolytes, though, can be useful. You may have heard me mention phosphate a couple of times on ward rounds, but it can be useful. Often not necessarily as a marker of malnutrition, because so pre-morbid it will be or can be, but in the acute setting, especially in acidosis, phosphate will act as a buffer, or can act as a buffer. So the level of phosphate isn't that useful, but the trend of phosphate during feeding can be useful, because a sudden and precipitous decrease in phosphate can suggest refeeding syndrome. And there has been some data in weaning that maintaining phosphate in the recovery patient, it can be beneficial. Right, so how much do we need per day? So fairly simply, to live, you need water, you need electrolytes, you need protein, and you need carbs. Water, 30 mils per kilo per day. For some reason, I remember 1.6 mils per kilo per hour. It doesn't really matter what formula you remember, but roughly your maintenance fluid requirements are 30 mils per kilo per day. And then to remember how many calories you need, I just think of it as around the same. So it's between 20 and 35 calories per kilo per day. So it's roughly the same as water, a little bit less, a little bit more. It does depend a little bit, and I'll talk a bit about how you gauge how much they need. In terms of protein and nitrogen, I never remember this, but the values are there, and that's why we have people like Moira and Jess. And then in terms of electrolytes, the ones I tend to remember are the sodium, potassium, because it's sort of 1 to 2 millimoles per kilo, and potassium's kind of off the bottom end of that, 0.7 to 1. And so those are your maintenance requirements. It doesn't account for losses, and it doesn't necessarily, it's maintenance in a healthy person, so it also doesn't account for losses associated with critical illness. But in terms of just giving you an idea of how much people need per day when they're reasonably well, that's what they are. So the important ones to remember, I think, are water and carbs and sodium and potassium. If you can remember those, fantastic. So that's the maintenance requirements. But how do we work out how much energy patients actually need? So there are techniques available that we don't use at the Royal, mainly for cost reasons, but the kind of gold standard is indirect calorimetry. And essentially what you can see a little man in a bubble there. So he's obviously not on a ventilator. If you're on a ventilator, you just connect a little device, a little electronic device that measures oxygen consumption and CO2 production, and then you add it into this weird formula, and it gives you an idea of what the energy utilization is for that patient. I mean, it's not, so I'll mention it in a minute, but one of the problems with indirect, amongst the problems with indirect calorimetry, A, is the cost, but B, there's no evidence of benefit. So even if you very accurately measure energy expenditure and energy requirements, there's no data to suggest that it actually makes any difference to the patient's outcome, but you feel a lot better because your numbers match. What we tend to do, and what our nutritionists do, is use these predictive equations, which are more or less slightly hopeless. I mean, they do give you an idea of roughly how much energy a patient requires for the level of illness that they have. I think I took it out. Yeah, I used to have a little graph, a little table saying what it is, but essentially predictive equations will, they use weight and height, but they also look at what disease the patient has. So for those of burns and those of sepsis, they have different requirements. The equations also, some of them also suggest sort of starting with lower calorie requirements to start with, and then building up. So when you're in that ebb bit and that early flow catabolic period, you actually don't utilize nutrition very effectively. So it suggests sort of lower nutrition for those periods, and then as you start to recover, you have sort of multiple factors like 1.25, for example, for sepsis, which is added on. But one of the problems with energy requirements, so we tend to do it per day, but actually it varies a lot during the day and during a patient's admission. You know, a patient lying in bed reading a book during their well period needs less energy than the one who's been thrown around by the physiotherapist. So, you know, the amount of energy a patient requires does vary during the day, but also during their period of recovery. And so that's why the equations aren't necessarily that useful. That's why calorimetry works better, but it hasn't been demonstrated that the cost benefit ratio isn't there. Okay. So feeding. So how do we feed? Now, I always tend to talk about Goldilocks on not just because I'm a bit weird about nursery stories, but also because for ICU it tends to make a lot of sense. But it did occur to me the other day that actually an awful lot of people who we work with actually have never heard of Goldilocks. So, you know, international medical graduates or people from non-European backgrounds have not heard of Goldilocks. So I don't really know who's listening today, but if you haven't heard of Goldilocks, it's basically a nursery story about a little girl who goes into a bear's house and basically tries all their food and all their chairs and all their beds and moans about when they're too hard and they're too soft, and she keeps trying to find the one that's just right, in a nutshell. So Goldilocks is really represents what we try and do ICU nowadays. We know from a lot of evidence that giving too little, so too little nutrition, not doing enough physio, not giving enough fluid, worsens outcomes. And in nutrition, not too little is bad. So mortality goes up the more you're negative in relationship with your negative energy balance. But also too much is wrong. And there were a lot of studies in the 80s, you know, giving lots of people oxygen, lots of people dobutamine and dopexamine and various things to try and, you know, optimize oxygen delivery and make it better and flood everyone with oxygen. And those patients didn't necessarily do very well either. The early paper suggested amazing recovery, and the later paper showed it was a load of nonsense. And we know too much can be bad for you. Too much oxygen can give you pulmonary fibrosis. Too much fluid knackers your lungs. So a lot of what we do in ICU now is about just getting it just right. With nutrition, too much energy, too many calories does lead to worsened outcomes, not necessarily mortality, but normally delayed discharges, longer time on ventilators, more problems with homeostasis in terms of glucose control, and certainly with TPN or PN, liver dysfunction. And the other thing on this slide to remember is that also the other thing you have to bear in mind is the non-nutritional energy that we give patients. So we give patients propofol, which is a reasonable amount of fat constantly. And our nutritionists do include this, but if you ever have to work out nutrition yourself, always bear in mind that there is a calorie input from fluids like dextrose, fluids like propofol. So that has to be included in the calculations. So how do we feed? Well, probably the best way is the patient that eats and drinks, but enteral feeding is what we generally try and push fairly early. It is more physiological than parenteral nutrition, but in of itself isn't really that physiological. We don't usually graze at 42 mils of energy or of nutrition per day. We don't normally eat overnight. So the way we actually eat is, is bolus periods, 3 times a day. But it seems to work. Generally, the guidance is start enteral nutrition as soon as you can, ideally within 48 hours in the normally, what's the word, not well nourished, appropriately nourished patient. And because it improves outcomes. And when they're early ill, when in the early stage of the illness, you don't necessarily need to push nutrition enterally up to 100%. They are starting at a lower rate. Something is better than nothing. And in fact, if you try and meet their energy requirement, most of it will transit. It won't be absorbed. There is some evidence looking at around post-pyloric feeding. It probably is slightly more. It probably is better, but it's more complicated, more difficult to get these tubes beyond the pylorus and get them to stay there. More to the point. And as I mentioned, bolus feeding is more physiological, but actually causes quite a lot of problems in terms of spikes in sugars, regurg, and vomiting. So enteral is the primary way, and I think every patient should be enterally fed as soon as possible. But there are patients who can't be enterally fed. But it's always good to try and question when patients can be enterally fed, because that is the most important way of doing it. In terms of gastric volumes, well, we used to worry about sort of 200 mils in 4 hours. Nowadays, we seem to allow 400 mils in 4 hours of aspirates. So if you're aspirating less than that, then carry on the feeding. But it's also worth bearing in mind, low aspirates do not necessarily mean the patient is absorbing what you're giving them. Some will be transiting, so not being absorbed at all, so they'll get diarrhea. Sometimes the NG tube is poking above the fluid level, depending on how the patient is positioned, especially with sort of head up position. And so you won't get high aspirates until suddenly you get 1.5 litres out. So don't necessarily be falsely reassured by low aspirates, but we can tolerate higher aspirates than traditionally we would do. And prokinetics are strongly advocated in most guidelines for patients in whom absorption seems to be low or aspirates are high. Complications enteral feeding, well, this is the one we worry about. So NG tube in the lung, and it's not so much the tube, it's the feed. But also diarrhea is actually really common. And so a lot of times we're asked, does the patient need to be in the side room? Have they got C. diff? Well, one of the questions in my head is always, well, actually, when did they start feeding? How long are they not being fed for? And when did their bowels start working? But patients do get abdominal pain. They can still get symptoms of reflux sometimes. Aspiration, obviously, microaspiration is a problem. But the kind of fatal one tends to, well, it can be fatal, is feeding into the lungs. Parenteral nutrition, in theory, should be fantastic, because you're giving you with your careful equations and your calorimetry, you can identify how much energy the patient wants, and then you put a line in and you give them exactly what they need. The problem is it doesn't really work like that. Early parenteral nutrition, and there are a couple of studies that really demonstrate this, but early parenteral nutrition is essentially associated with worse outcomes. There's the infection risk of lines, so I hope we're slightly better nowadays in managing lines, but there are also delays in how long they stay in ICU. They tend to be ventilated for a bit longer. Again, the evidence isn't entirely clear-cut, so it slightly depends on the trial you read. And there is some suggestion of being increased mortality, but again, that's not clearly proven. But a lot of these some of them slightly subtle complications go away if you delay for 7 days. So in the normally nourished patient coming to ICU who cannot feed enterally, you can wait 7 days, according to the data, before starting parenteral nutrition. And there's some data to support that. There are some data. So one of the big trials is the EPANIC trial that essentially, we'll come on to it a bit more, but was looking at nutrition, looking at parenteral nutrition versus enteral nutrition and combinations. But essentially, late initiation of feeding was associated with improved earlier, more people were discharged earlier, and the same with discharge from ICU and discharge from hospital. So early initiation of parenteral nutrition is probably and likely not to be beneficial. So what is in TPN? Well, it's mainly sugar with some fat. Essentially all it is. They do put protein in the form of amino acids, and can modify the electrolytes, and can add some trace elements and vitamins. There's a lot of small data sets about micronutrients. Again, it's very hard to show strong benefit in any of these things. There's some support for glutamine, but essentially most of what we give in TPN really is fat and sugar. So a bit like NG tubes, there are problems with parenteral nutrition. The line can go in the wrong place. So they need a central line. They need a clean. It needs to go into a large vessel. It needs to be clean. The lines move and can end up in the wrong place. So I think Ian McLaren will remember this patient. So this is a central line, which at first glance you may think is in the right place. If you start talking about rotation and things, but it's not. So this is a central line for TPN in a lady who had absolutely impossible veins, who the intensivists tried very hard to put lines in, but vascular access thought they could do it better, and they put one in and were triumphant when they managed to get a line in. Unfortunately, it ended up in the epidural space. Fortunately, it was noticed by a radiologist and she wasn't fed down it, but central line position can be a problem. So kind of FRCA type question, this enteral nutrition versus PN. The main advantage of parenteral nutrition, and its slight disadvantage, but its main advantage is that you know what the patient's getting. They are absorbing 100% what you give them, because it's not requiring any GI tract, so that they are getting the sugar you give them. The problem is, and I'm coming on to this, is actually giving them what you think they need actually may not be what they actually do need. And enteral nutrition, A, is a lot cheaper, but the main thing is there's some, it improves the gut health, reduces the risk of ulcers, and there's a degree of autoregulation as well. So patients receiving enteral nutrition will again absorb the energy they need, not what we think they need, if that makes sense. So it's harder to overfeed someone with enteral nutrition than it is with parenteral nutrition. Looking at mortality, again, basically all the trials, and this is quite old now, but all the trials, the confidence intervals all cross one basically. So mortality isn't really there in all the studies. There are some studies that do suggest enteral is safer. In terms of infectious complications, and that's probably related both to the line and also to basically you're instilling a bacterial solution, a solution that bacteria like into someone's veins. It's not surprising infections are higher in the parenteral nutrition group. The truth is, nowadays we tend not to do enteral versus parenteral. We tend to do both, which is also why you hear nutritionists not talk about TPN. They tend to talk about parenteral nutrition rather than total parenteral nutrition, because we generally try and avoid total parenteral nutrition. And is this combination treatment is probably the right way to do it. When to do it? Well, it can be difficult to optimize with enteral nutrition alone. So there'll be patients with an ileus, for example, or patients whose energy requirements are far in excess of what you're able to deliver with enteral nutrition. A lot of our patients already come to the unit malnourished. So they need some support because they're already trying to catch up on what happened before they got ill. It can take, in patients in whom it's taking over 3 days to get up to their target regime because their aspirates are really high, that's another group who would probably benefit from some parenteral nutrition. So early parenteral nutrition is bad, but when is the right time to start? When should we add in parenteral nutrition? And again, this was a study looking at this. I think this is panic as well, but it could be the other study. I can't remember now. Anyway, looking at enteral, basically co-nutrition. And they had sort of 2 groups that were early initiation and late initiation groups. So the enteral groups, in terms of the energy that they were getting or that they were able to tolerate, both the early in the kind of early and late, so early and late initiation refers to the parenteral nutrition, not the enteral nutrition. So the enteral, you're reaching about 80% of your requirements at day 15, which is quite late. But by day 7, day 9, most patients are reaching their energy, heading towards their energy requirements. The late initiation groups were the ones who had their parenteral nutrition started at between day 7 and day 9. And the middle chart just shows that, and the final chart shows kind of the total energy. But the key thing from this is to show that if you start parenteral feed early, you reach 100% straight away. And if you notice with the enteral nutrition, no one reaches 100%. And so if you co-feed, you're going to more likely reach that target. And the outcomes of that essentially are what I said earlier in the panic study. Patients who were fed early with TPN in combination with enteral nutrition had worse outcomes, so delayed discharges and longer term time on the ventilator and more infectious complications. Mortality wasn't changed very much. And that delaying parenteral feed was associated with slightly improved in outcomes. The main thing is we don't need to start PN early. We can wait. So guidance nowadays seems to be day 7 seems to be the main cutoff. I think we tend to use day 5 to 7. Slightly dependent on the patient. So if they're not tolerating any enteral feed, once they get to day 5, we tend to start enteral. We start putting lines in, and they then get their parenteral nutrition. But day 7 seems to be a reasonably safe number to aim for. So patients should meet their energy requirements, or at least be heading towards energy requirements. Or rather, they should be absorbing some energy feed by day 7. If they haven't, that's when we should start adding the parenteral in. Okay, so this is just a little bit of what I said earlier. There's a lot of stuff about micronutrients, glutamine, fish oils. That's where the omega-3 fatty acids comes in. Again, fairly weak evidence for all of them. Immunonutrition, something that's quite topical when I was in SHO, and again, there's not a lot of evidence for or against using these adjuncts. I think glutamine is the main one that is added now. So the sort of final bit, I think, is the refeeding syndrome, which is something we see on ICU. I think we actually see a lot more than we think we do. But again, we have dietitians who help us out. It's been recognised as a problem for a long time, but it's probably mostly formally recognised at Bergen-Belsen, where POWs were found by American troops, mainly English POWs, if I remember rightly, but they're multinational, in starved conditions. These patients were skeletal. I'm sorry, these soldiers, prisoners were skeletal, and the Americans, understandably, full of humanity, felt what they needed was something to eat. So they were giving them their chocolate bars. They'd hand out all the food they had to help these starving people, and unfortunately, a few dropped dead in front of them, or died over the next few days. And this is where sort of more formal recognition of refeeding syndrome came about. And it's really where patients or individuals who have reached a point of starvation that they essentially reset a lot of their metabolic processes, so their potassium levels have sort of been reset to slightly, well, no, it's essentially got metabolic abnormalities due to starvation. So they've kind of got normal potassium levels, but it's mainly been achieved, or low potassium levels, mainly achieved by muscle and protein degradation. And what happens is you feed those patients, you cause them to release insulin, which up until then may have been suppressed for 8, 10, 14 days. And that insulin is what leads to the complications. So what do you see, or the risks? So a bit like with alcohol, which is essentially a malnourished state. So you can essentially refeed alcoholics. You get confusions, comas, wernicke's. Cardiac arrhythmias tend to be the fatal bit. So sudden reductions in potassium in already weakened cardiac muscle, respiratory failure, dysfunction in the livers, and pathological polyuria. So what causes it is mainly a consequence of insulin. And you can it's easy to remember it because, if you have hyperkalemic patients, what do you give them? You give them insulin. If you have diabetics in DKA, what do you worry about? Well, you worry about the acidosis, but you also worry about hypokalemia. And it's all insulin related. So malnutrition leads to glucose mobilization, and eventually, as you saw at the beginning, these sort of catabolic pathways, as your protein is used as a fuel source. You then give the patients a happy meal, and they secrete a lot of insulin that hasn't been secreted for days or weeks. And that insulin secretion does what insulin does, which is increase glucose uptake, good, but also causes changes in thiamine. Mainly from our point of view, you'll see a fall in potassium as that potassium is mobilized into the cells by insulin. You'll see phosphate as well, and this is why phosphate is useful, can be useful. That fall in phosphate day to day can suggest a degree of refeeding because phosphate and potassium are both mobilized intracellularly, and magnesium. And so that's what the insulin does. And that's what you see. And so it can be fatal. It's rarely fatal in ICU, but it's something we should be aware of and should try and anticipate. Partly the thiamine, particularly in terms of the risks of Wernicke's and Korsakoff syndrome. So that's often why we'll start them on Paradex to try and replace the vitamins that are going to get mobilized by the insulin. Who's at risk of refeeding? Well, people who are starved, obviously. Patients who have had acute weight loss, and patients who have a process for causing, have a history of alcohol, but also things like heart failure, not being adequately nourished prior to esophagectomy surgery. So patients have a history that may predispose them to malnutrition. Drug users, patients who take opiates, appetite suppressants, essentially with opiates, and also a disinclination to eat. Acute or severe depression or other psychiatric illnesses can also contribute to not eating and appetite and weight loss. And also people with low BMIs. But a lot of the things you can do earlier that I mentioned, checking fat pads, looking at the temporalis muscles, give you an idea of what their nutritional state probably was prior to becoming acutely unwell. But I think a lot of our patients in ICU we often give vitamins. I mean, we seem to give far more vitamin infusions to patients now than we ever used to, and I think it's probably a good thing. I think we're much more alert and much more aware of refeeding. And again, I think a lot of our patients, we're taking more chronically ill patients now than we used to. So how do you manage it? Well, I've just mentioned it really. Give them vitamins, vitamin B1, which is thiamine, and you don't give feed at full rate. You know, you reduce the amount of feed you give, so you gradually increase the feed, so you try and reduce that insulin spike, which is the main driver of the refeeding syndrome, and keep an eye on their electrolytes. And I think most of us do this now, but this is why, and it's why you're allowed to talk about phosphate and wood rounds when it's related to refeeding. Right, so I'm reaching the end. So in summary, critical illness, it's a catabolic pathway. It's hugely catabolic. I still am astonished by how much muscle mass patients lose and how quickly they lose it. On ward rounds, I look at patients only been for 3 days and they've already mobilized nearly all their protein. It's incredible. Too little feed is bad for you, too much feed is bad for you. The Goldilocks of intensive care. Generally feed enterally, within 48 hours. I mean, most patients are fine for 24 hours and up to 48, but feed enterally early. And if they can't tolerate enteral nutrition, you can wait for 7 days if they came to hospital, appropriately nourished. But if they were malnourished, you may by day 3 to day 5 is what we should be looking at. Early parenteral nutrition is harmful. I'm not sure I've said a bit about this already. I mean, one of the theories why that is the case relates to the ebb and flow. Again, because the GI tract to an extent can auto-regulate. So one thing that has been shown in sepsis, particularly in shock, is that the mitochondria essentially enter this form of hibernation where they can't actually utilize energy, or rather they can't utilize fuel to produce energy. So when you give someone intravenous energy, it's forcing the body to handle it, and that is a process that is not really optimal during early sepsis or during shock, and probably leads to generation of things like free radicals. But it's much harder for the body to manage this very non-physiological way of giving nutrition. Whereas NG nutrition or enteral nutrition, there's a degree of auto-regulation. So what the body doesn't need to absorb will either come up as vomit or transit, and resulting in diarrhea, which isn't ideal, but there's a degree to which the tolerance of their feed is actually determined by the physiological processes in response to infection and such like. So that's probably some of the theory behind why parenteral nutrition is harmful. I actually think quite a useful, interesting study would you look at appetite. So one of the things I often ask patients is if they're hungry. And I think one of the indicators of recovery is hunger. Now, obviously, you can't ask it to a ventilated patient, but to non-ventilated patients, I think, along with mobilization of fluids, so high urine outputs after a few days with sort of quite low urine outputs, and appetite are useful, I think, indicators of recovery, of entering that flow anabolic state, coming out of that flow catabolic state. And it'd be lovely to know what the true signals are for appetite. But anyway, that's another research project in the future. And the final thing is just be alert to refeeding syndrome, based on what I said. Okay, I think, yeah, if you're doing FRCA or FICM, these are sort of questions that might come up. Right, any questions? Anyone hear me? Okay. Any questions about Oh, hello, Mike. I can't hear anything you're saying if you're talking.
Oh, it's because I haven't started talking yet. So is there a way to be able to tell where you are in the starvation period?
Not that I know of. In patients who can't talk to you.
Yes.
So there are these SLG1, well, I can't remember what it is now. There's these receptor antagonists that are being used as appetite suppressants, which seem to work quite well, and used in diabetic medication. And it may be the monitoring that signal might be a way of looking at hunger. But no, I'm not aware of any marker we can use other than saying, "Are you hungry?"
Fair enough. Thank you.
Sorry about that.
I wasn't aware of anything. It was just if you knew anything different.
No, afraid not.
And in your mind, have you got us to because I think the most important things for people here is about when you start feeding and what you think about feeding. And I've still got a process in my mind where I look at the patient in front of me. This is taken from, I think Dan Harvey wrote a bit. It might be in one of the BJA things a few years ago about how you make a decision. And it's that first process of, can this person demand feed? And then if they can't demand feed, are they going to within the next 24 hours? And then if they're not going to be able to demand feed in the next 24 hours, it's then placing an NG and starting NG. And if they're not going to be able to tolerate that within the next 24 to 48 hours, then you should be considering PN. And that's an earlier process than previously. But then as far as I understood, all of the studies that looked at the risk of PN were based on multi-lumen catheters. And it was actually the complication of the catheter rather than the PN itself. And when it's appropriately managed by dietitians, etc.
Yeah, so the couple of points. I mean, I think when to put an NG tube in is something I didn't cover, and you're absolutely right. I think that, I mean, that approach sounds very sensible. You know, are they likely to be able to, keep up with? Are they likely to be able to take orally, and to say demand feed appropriately within the next 24, 48 hours? And if they're not, then an NG tube would be appropriate. So can they meet their calorie? Can they meet their predicted or known energy requirements? I mean, there is maybe a question about if they're not eating because they're not hungry, should you be pushing it? I'm not sure. There's a lot of data about that, because actually we give a lot of appetite suppressants. We give opiates. So a lot of what we do does suppress appetite. So it's not entirely surprising. So I think hunger can be misleading in the early stages where people are acutely unwell. And also, but the other thing to bear in mind is that, when if you've had flu or more recently COVID, you may remember not feeling hungry. And there probably is a physiological reason for why you don't feel hungry, is that your body actually can't utilize the energy you eat. So there's no point eating, but you should stay hydrated, but you don't necessarily need lots of energy or lots of food, because that's an active process to metabolize it. So yeah, but in terms of when to put an NG feed in, it does make sense to look at the patient and say, look, are they malnourished or not? How ill are they? And are they likely to be able to eat appropriate amounts within the next day or two? And if they can't, then an NG. When to start PN? Yeah, I mean, yeah, absolutely. A lot of the studies a lot of the infectious complications do seem to relate to the lines that are used. The later studies, I think ePanic and things were much better. And I'm not entirely convinced that we can blame lines for delayed hospital discharge and delayed ICU discharge. That's my view. That is not, lines are part of it. And having said that, all the patients tend to have lines anyway. So I don't know if you can control for it. But yeah, putting lipid and fat through a line, it does make it more likely to become infected. I do generally lean towards the sort of national international guidance, which is day 5 to day 7. Most of the international guidelines, there's Aspen and what's the other one? it's on my ESPN, but there's a European Society, there's the American Society for Nutrition, who, and Canadian guidelines as well, all recommend about day 5 to day 7. It varies, but day 5 to day 7 for parenteral nutrition, dependent on the nutritional state of the patient in front of you. So if they came in malnourished, then you should start earlier. But if they come in appropriately nourished, then you probably gain the risk and not the benefit of early parenteral nutrition. Most of essentially, there's, irrespective of your view on the lines, there isn't evidence of benefit of feeding earlier than day 7. So if you feed at day 3, it probably doesn't make a difference compared to feeding at day 7, probably. So that's why there's no real harm in delaying. If you delay longer than that, certainly beyond day 14, that's where you do see harm from underfeeding. But yeah, sorry.
The thing you have to remember about that is that the majority of people, I know it's a lot easier for an elective patient, but for emergency patients coming to us, we assume that they've been eating absolutely fine up until the day that they're admitted or when the symptoms start.
Yeah.
But the majority of them haven't been well for 2 or 3 weeks beforehand. Yeah. And we are, well, I'm not sure when I last did a must score. Do you remember?
I mean, you're absolutely right.
Very good at it.
Yeah, no, you're absolutely right. It's, you have to make a judgment based on the patient in front of you and have a view on their nutritional state prior to admission. And you're right, if they haven't been eating properly for 2 weeks, then yeah, there is an argument for, there is an argument starting for parent nutrition earlier. No, I absolutely agree with you. Sorry, hang on, I've got I'll return from school. Yeah, so yeah, no, you're right, Mike. So I agree with that. You do have to make an assessment based on the history and what you see in front of you. Obviously, markers of skeletal muscle loss are slightly crude. That you have to have quite a lot of muscle loss before you start seeing loss of temporalis and loss of your fat pads in your thumbs. And so you can't rely on that. So yeah, a verbal or oral history is useful. But I must admit, I generally do side on slightly later TPN. I think there aren't many patients I'd be very keen on starting parenteral nutrition within the first 48 hours. But I think you just have to make a judgment.
Sounds good.
Okay, anything anyone else wants to ask about this extremely exciting topic? It is important.
Very important.
Yeah.
People's jobs depend on it.
I'm just trying to see how many eyes closed I can see. None yet. Okay. All right. Anything from Glenfield, if Glenfield is still there?
No, I'm still here. I think that's really good. Thank you.
Okay. All right.
Questions?
Okay. All right. That's me done then. Thanks, everyone.
Thank you so much. That was great. Is there a QR code or something to do?
No, wasn't last week. Just got no votes.
No votes? Sorry. Yeah.
I've got a certificate which I immediately.
Oh, you should
Simon, are you still there?